Hello and welcome to the second seminar of Public Health 1, which is about prevention and diagnosis. Today we will learn the basics of preventive medicine in addition to a special focus on screening and diagnosis. Let's start. Why prevention? Why it is important for health systems to try to prevent diseases? In fact, if you look at any disease, not only COVID-19, as you can see in this uh, graph, but in general, all diseases look like this one. We have two separate groups of individuals who are at risk or who already have this disease. The first group that are in darker colors, the detected cases, these are the cases that we can see by our eyes or we can record them. Those include those who die from the disease or the mortality cases, and also those who are diagnosed or already recorded as active cases or previously active cases, which are the symptomatic cases. So this is just one portion or a proportion of the whole burden of this disease, because there is another number of cases that are undetected. This includes the asymptomatic cases, the cases that have the disease already, but they do not show any clinical symptom yet. Also, we have the people who are surrounding those asymptomatic and active symptomatic cases, which we call the people at risk. So this graph that you see here, or this large pyramid that you can imagine, is the real burden of this disease. And our capacity as health systems and health practitioners is very limited to see this real burden, because we can only, as you can imagine, detect this small portion of the cases. That's why we need to keep in mind that the real burden of diseases that we deal with is usually, and sometimes it's always, beyond what we already recorded and what we plan to deal with. So we need to be careful and we need to act proactively in order to control the diseases and try to probably reduce them or eliminate them from populations. Okay, so this was just a quick idea for why prevention is important, and the answer is very simple, because what we see from the burden of diseases is just a small portion or a small part of the whole burden or the real burden of the disease. Then, as a quick reminder of last week's seminar or last seminar, we need to remember the natural history of disease. This is the universal theory that explains the timeline of any disease, not only infectious diseases, but any disease. Okay, so the process starts with a human who is in a wellness state. So this human is still healthy or still fit. But this human, one day or at a certain point, will start to have a disease or start to suffer from a disease. And this move or this migration from wellness to illness state will lead to outcome which can be recovery or mortality or sometimes long-term morbidity or long-term disability. So these outcomes of the disease will happen after the disease started to manifest itself clinically. Okay, but you have to remember, because the move from the wellness to the illness state has been already triggered by risk factors. So there are different types of reasons or risk factors for why people get sick. These include environmental risk factors like air pollution or lack of sanitation and access to clean water, for example. These are just like examples for environmental risk factors. We also have biological risk factors. Think about COVID-19. So all viruses, bacteria, fungi, parasites, and all these microorganisms that lead to infections, these are considered to be biological risk factors. Also, we have psychological and psychosocial risk factors, including stress and anxiety that are induced by several factors in the social environment. Think also about genetic risk factors and family history for some groups or some individuals. So all these different types of risk factors will push humans to be sick at certain point of their lives, and after they are sick, they will experience certain outcomes based on the degree of illness and the effectiveness or the efficiency of the medical intervention that they will receive. Okay, so this is the process in very simple words. So let's see how the process is fractioned or divided scientifically. First, we have the stage of susceptibility, and remember, this is the time when the humans are still in wellness state apparently, or they seem to be healthy. They have no clinical symptoms, they have no even subclinical changes, I mean any pathologic changes, but at the same time they have been engaged actively with risk factors. So a good example for this can be smoker. So the smoker at the moment, they accept or they show no abnormalities or no disease, but we know that at certain point of their lives they will start to suffer from certain diseases. Okay, so this is a stage of susceptibility. This is when the humans are engaged with risk factors. Okay, then we have the stage of subclinical disease, and during this stage the disease already started to change the functions, I mean the physiology of the human body, but yet there is no clinical symptoms to detect these changes. So these changes had been already started pathologically, as I said, in the subclinical level, I mean below the clinical threshold, but we know that at certain moment these changes will increase and they will be more prominent, and this is a moment when we see the clinical disease. So after the patient started to have clinical symptoms, they move from subclinical to clinical disease. So the first day when the human started to cough or have headache or suffer from diarrhea or any other clinical symptom, this is the first day of the clinical disease. Then the clinical disease will lead to certain outcome that we probably can imagine, like mortality or morbidity or maybe total recovery, and this disease outcome will be highly dependent on the quality of healthcare and the degree of illness or the invasiveness of the disease that they will experience. Okay, so this is the 4 stages of the disease development. Remember that we said that for the second stage, which is the stage of subclinical disease, we can measure how many days or probably how many weeks the human stayed within this stage based on two metrics or two days. The first day is called the day of exposure, and the second day is the day of the onset. And these principles are exclusively applicable for infectious diseases, so you have to be careful. This subclinical disease stage cannot be measured for non-communicable diseases like cancer or diabetes or cardiovascular disease or any other chronic condition or non-communicable disease. Why? Because we don't know exactly when was the day of exposure or when the disease started, because the changes that lead to these diseases are usually time intensive. They take years, and that's why we don't know for sure when the disease started, and also we are not very sure when the disease started to clinically manifest itself. Sometimes we can find it by diagnosis or opportunistic screening, but yet this is not exactly the day of the onset. So again, incubation period, onset, and exposure day, these are all terms or concepts that are exclusively applicable for infectious diseases. Infectious diseases, for example, this can be influenza, COVID-19, HIV, and many others. Okay, so the diseases that are transmitted based on pathogens or infectious microorganisms, these are the ones that we can apply the concept of incubation period and calculate it in very specific measurements. Okay, so if you would like to control these 4 stages, we have the opportunity to do so by using various applications or interventions from preventive medicine. The first group of interventions we can apply at very early stage, and this is before the stage of susceptibility. So before the people get started or getting engaged with risk factors, we can do changes in their environment. So primordial prevention, as you will see later, is focused on the changes that target the environment itself. We don't try to change the human behavior here. We will later focus on the humans. But in the very first stage, which is the primordial prevention, we focus exclusively on the environment. So think about any policy that will change the environment or change the society and how it functions in order to make the risk factors more away or more distant from the humans and from the population. Okay, so primordial prevention aims to modify the environment, okay, to make it safer, to make it healthier and more hygienic. Okay, so this is the first stage. Then the second stage, which is stage of subclinical disease, we can prevent it or we can stop it if we apply primary prevention. So primary prevention is the stage when we try to focus on humans, and here we try to protect the humans from the risk factors. So we know that risk factors are already established in the society or in the community or in the environment, and that's why we try to make the people protected or probably immunized against these risk factors. So a good example for primary prevention is vaccines, and we will learn very soon also other applications or other examples for primary prevention. But remember that primary prevention focuses on human, and probably also the other two levels of prevention like secondary and tertiary prevention will focus on humans. But you have to remember that the primary prevention is the first level of prevention that focuses on humans, and it tries to prevent the humans from getting infected or getting diseased and starting the subclinical disease. So it technically lies here between the stage of susceptibility and the stage of subclinical disease. So if primary prevention is effective, then the stage of subclinical disease will be completely shut down. Okay, then we have the stage of clinical disease, and we can stop this stage of clinical disease and early engage with it through secondary prevention. So secondary prevention takes place technically during subclinical disease in order to prevent the clinical disease. And this can be, if you think about it, in way of early screening. So when you screen a group of individuals or group of, let's say, women or children or whatever other population group for certain abnormalities like cancers or other diseases, you try to find the cases that have the disease already without clinical symptoms, which are the cases of subclinical disease. And when you find these cases, you will try to give them early treatment because you believe that early treatment can be more effective than later treatment, and that's why you prevent the clinical disease from emerging. Okay, so screening is a very good example for secondary prevention. And then we have the stage of disease outcome, which can be modified using tertiary prevention. And in the next slides, you will learn more about tertiary prevention and how it is different from clinical treatment. So once the disease is clinically present and during the stage of clinical disease, you can apply medical treatments, and you can also try to think of tertiary prevention. Clinical treatments will focus more on the short-term outcomes, which are the immediate outcomes or the acute outcomes of illness. However, tertiary prevention will focus more on rehabilitation or the long-term outcomes of illness and make it probably more favorable for humans and their survival. Okay, so these are the four levels of prevention: primordial, primary, secondary, and tertiary. Right, so let's start with primordial prevention. Primordial prevention, as we said earlier, focuses on the risk factors that can lead to illness, and all the changes that we can apply or all the interventions that we can apply as primordial prevention are policy oriented. So think about road safety. If you changed the laws and made more strict regulations regarding road safety to increase the safety of roads, then you indirectly affect the level or the rate of accidents and injuries. Think about tobacco taxation. When you increase taxes or prices of tobacco, you make them less accessible for some population groups, especially the high-risk groups, because we know that high-risk groups of smoking are usually those who have lower socioeconomic status or lower education levels, and that's why when you make tobacco more expensive or more highly taxed, in this case you indirectly as well affect the access of these groups to this harmful substance. The same also applies for sweetened beverage. When you increase taxes on sweetened beverages like cola and others, you try to make them less accessible for children and other risk groups. Okay, gender equity. So all the policies that will make genders have more access or more equal access to market or sorry labor market and other areas in the society will increase the chances of equal health outcomes or equitable health outcomes for everyone. Think about environmental risk factors and how can we engage with them. For example, climate change. So all the policies that will try to limit the impacts of climate change are considered to be primordial prevention or interventions that are under the group of primordial prevention. The same for air quality, the same for water sanitation, and then we have behavioral risk factors that we can try to influence through policies like birth control, parenting styles, and nutrition as well. Then social risk factors and social disadvantaged groups like minorities and underserved groups. So all the policies that will give them better access to healthcare and equitable access to healthcare, let's say, are considered to be primordial prevention. The same for people with disabilities, their access to healthcare, education, and welfare, and other advantages. These are all considered to be primordial prevention because these led them to be better integrated in our societies. Okay, this graph represents a real example from South Africa between the years 1961 to 2001 for the rates of tobacco consumption and the real retail price of cigarettes. As you can see in this gray graph or this gray line, the prices of tobacco was decreasing between 1961 until 1993, and so during this period the consumption rates had been increased significantly or gradually. Then in middle of the 1990s or at the beginning or the first half of 1990s, there were new policies that aimed to increase the prices or taxes on tobacco. That's why the consumption rate started from the mid or the second half of 1990s until the beginning of the new century to decline, and at the same time the prices were getting high. So this graph is a good example, very good example by the way, for how primordial prevention can improve public health outcomes. Okay? So this is primordial prevention. Then we have primary prevention, and as we said, primary prevention is the first level of preventive medicine to focus on humans and try to protect them as individuals from getting diseased or getting infected. So this level of prevention, which is primary prevention, has two modes, and very soon we'll explain them. The first is called health promotion, and the second is specific protection. Okay, so vaccination, for example, is, as I said earlier, one of the very good examples for primary prevention. We have different type of vaccines like childhood vaccination, and this is the group of vaccines that are recommended on the national level for children from day one until the age of 18 years. Sometimes it's less than 18, but yeah, this is the maximum. And the number of also of required versus recommended vaccines for this population group significantly differ from a country to another, and you have to revise or review the recommended vaccines and required vaccines in your country in the future when you start to practice your profession. Also, another example for vaccinations is the DPTs, diphtheria, pertussis, and tetanus booster vaccines, which are supposedly given every 10 years. And as a future doctor or future medical practitioner, you need to watch this calendar and make sure that you are continuously protected. Seasonal influenza vaccine, which is supposedly administered every year, and it is important as well for you as future doctors to be protected against seasonal influenza. Malaria vaccine, which is a very new vaccine which has been approved a couple of years ago, and this vaccine is recommended to be given before travel, especially if you are traveling for high risk areas. or high-risk countries. For example, if you would like to go for medical convoy or volunteering camp, then before you go to volunteer, you need to make sure that you are properly protected. And then other kind of vaccine is human papillomavirus vaccine, which was approved, I would say, also recently, not very recently, like it was approved almost 15 years back, but it's still very important to help our populations and help our people to take it, because as I said, it's a new vaccine and it's not required yet in most of the countries in the world, and that's why we need to increase the public awareness about it and increase also the public motivation to uptake this vaccine. Why it's important? Because human papillomavirus is not only responsible for these infectious lesions or infectious disease that we see, but also it's associated with various other types of cancers, including cervical cancer, and it's the leading cause of these cancers, by the way. So if we manage to prevent this infection, we indirectly protect the people from getting cancers in the future. So it's very important, and now it's not only recommended or limited for girls but also for boys. So it's recommended for all genders, and it's recommended from early age until early adulthood. Okay, so these are examples for vaccines that we recommend usually nowadays. Smallpox is a disease that was very prominent in previous centuries, I would say, and it led to hundreds of thousands of mortalities throughout the human history. But in the year 1979, the World Health Organization and the entire world community celebrated the reduction of this disease. So today we have no single case of smallpox, and this is a great achievement for humanity. And by the way, for your information, smallpox is by far the only disease that has been eradicated from the world and became part of our history. But we are very close today to eradicate other diseases, including polio. So poliomyelitis, which is another infectious disease that's responsible for handicapping of children, this is how we call it, is very close to be eradicated from the world thanks to the joint efforts of Gates Foundation, the World Health Organization, and Gavi. Okay, so these are quick look on vaccines and how they can change the face of our world. Today we have less and less cases of infectious diseases because vaccination campaigns that started probably hundreds of years ago from the beginning of the 19th century. This is when the first vaccination campaign was like approved in the UK, and then in other countries in the West, and then now in the whole world. This, like I would say, continuous efforts of vaccinating populations led to significant reduction in infectious cases or infectious disease cases in the world, and also less number of mortality. You have to be careful because vaccines are not approved in just one day, or they are not thoroughly reviewed before they are getting approved. In fact, they take months or sometimes years in order to be approved by drug regulators. First, we have three phases of clinical trials called phase 1, phase 2, and phase 3. These phases of clinical trials take place under supervision of competent authorities in order to ensure that the vaccine will be efficacious or will have acceptable efficacy. So efficacy of the vaccine is how good is the vaccine in preventing the infection among a group of volunteering individuals. So those individuals who are volunteering to join vaccine trials of vaccine manufacturers or vaccine companies are monitored very rigorously in order to see their outcomes within specific periods of time to measure the efficacy or how good the vaccine will really protect them. And this takes place not only one time or two times, but three times. And in each phase, the number of the volunteers is increasing. So usually the phase 1 includes between 20 to 50 patients. The phase 2 also have similar number, but in phase 3 we usually have hundreds of cases that are needed in order to ensure efficacy of the vaccine. Then we have to look at effectiveness of the vaccine, and this is how much the vaccine able to prevent infections in the real world population. So after the vaccine is approved and it's taken by the population, we keep monitor its effectiveness, and effectiveness of the vaccine is simply is how good the vaccine in preventing infection in real world among real humans or like real people. Okay, so these are not volunteers, these are just ordinary or average individuals like all of us. And once the vaccine is approved for everyone, like for example in COVID-19 case, after the vaccines were approved, we kept monitoring the effectiveness of the vaccine by counting the number of infections and whether the infections coming from previously infected or previously vaccinated individuals. And based on this measurement, we can say if these vaccines were effective or not. Okay, so this is the difference between efficacy and effectiveness. Efficacy is measured before the vaccine is approved for the public or given to the public, and it's done on volunteering individuals who are usually healthy people or healthier population. And after the vaccine is approved and after the vaccine is given to everyone in the society, we keep monitor its effectiveness, and effectiveness is how good the vaccine in preventing infections among real world or in the real world. Then safety of the vaccines is monitored from day one. So starting from phase 1 until phase 4 of clinical trials and studies, we keep looking at the side effects and adverse reactions of vaccines in order to ensure its safety. Okay, so safety is monitored in phase 1, phase 2, phase 3, and phase 4. Okay, you have to remember that vaccines, however, they are very important and very effective in preventing infections and controlling diseases. They are not largely welcomed by the public because we have a phenomenon that started probably 2 centuries back, which is called vaccine hesitancy. One of the reasons for the WHO to worry about, one of the top 10 reasons for WHO to worry about the future of humanity is vaccine hesitancy. So it's considered to be one of the top 10 threats for global health, according to WHO. And vaccine hesitancy is simply the delay of getting vaccinated, although the vaccine services are available. So if you see someone who is hesitant or refusing completely to take the vaccine or get vaccinated or vaccinate their children, even though the vaccines are available in their community or in their city, for example, in this case, we consider those people are as vaccine hesitant. And of course, we need to do something for them as medical students and as future medical doctors. You need to learn how to communicate with them, how to clear their worries and answer their questions, and definitely increase their confidence in getting vaccinated in order to protect themselves and their children. Vaccine hesitancy can lead to severe public health outcomes that can, for example, seen in some societies or in some countries recently with the outbreak of measles and other infectious diseases that have been eliminated in these countries probably few years back. Okay, so these are just examples for studies that we did during the COVID-19 pandemic for understanding and measuring the prevalence and risk factors of vaccine hesitancy. And we were especially focusing in our university and in our Department of Public Health on the side effects of vaccinations. That is also a part of the vaccine safety monitoring during phase 4. So after the vaccines were approved for the public, we kept an eye and we kept asking healthcare professionals and others about their history of the side effects that they experienced after vaccinations to see if there were any dangerous or any suspicious side effects that were recorded. Okay, so these are just examples for our work in Massachusetts University and in our Department of Public Health for vaccines and their safety and their hesitancy. Okay, so another examples for the interventions we do in primary prevention is chemo prevention. So chemo prevention is the use of drugs to prevent diseases. For example, when pregnant women receive folate, we aim to control or mainly to prevent neural tube defects. The same for newborns or new babies. When we give them antibiotics, ocular antibiotics specifically, we try to control neonatal conjunctivitis. Also for preoperative antibiotics. So before the patient started to have a surgery or to enter the like theater, we give them antibiotics in order to prevent surgical site infections that can happen during the operation. Prophylactic surgery, this is the surgeries that we do in order to stop potential cancers. So in high risk women that have a family history of ovarian cancer or breast cancer, we can do mastectomy or ovarectomy, which is the removal of ovary or breast in order to prevent them from getting these dangerous diseases or these cancers. Okay, this is another type of examples for chemo prevention, or sorry, for primary prevention, which is called chemo prevention. Then we have behavioral counseling, and behavioral counseling is when the physician or the doctor spend some time to discuss the risky behaviors of their patients in order to help them to make informed decisions about their health. For example, if you say a patient that comes to your clinic suffering from certain disease, regardless of the type of disease, but you know that those patients are smoking, and you think that smoking can be linked to the clinical outcomes that you are dealing with. In this case, this is the excellent moment to start the conversation about smoking and its negative impacts on health, and try to convince them to stop smoking. The same for nutrition and type or quality of food and its nutrition value for the humans or for the patients. Moderate drinking, you can also discuss with your patients their drinking behavior and drinking style in order to like decrease their or control their drinking frequency. The same also for sexual behaviors and sexual attitude in order to make the practices of our people safer and more hygienic. But before you start to have these conversations with your patients, you need to think of two questions. The first question is, does behavior change decrease the risk of the condition? So you need to think about the modification that you would like to have in your patients or your patients apply. Think about this change. Does it really affect the risk of the condition or not? If it's not really efficacious, then in this case, you are probably wasting your time and your patient's time. So try not to do it. And the second question is, can counseling lead to behavior change? Does your conversation with your patient will really help them to change their opinion or their views or not? If the answer is yes, then again, it's a good moment to start the conversation and help your patient to adopt healthier lifestyle. In this graph, you can see relationship between smoking cessation rate and the amount of time that is spent by doctors to consult the or discuss with their patients the risks of tobacco. So as you can see, the more time, the more hours that are spent with the patients, the better the rate or the higher the rate of smoking cessation. The same also in this graph, if you look at here, you can see four groups. The first group that have no counseling from their doctors, the second group that have counseling from their doctors, like their doctors spend some time with them, and the third group has counseling and also medication recommended by the doctors. And in the fourth group, we have the highest rate of smoking cessation or stopping to smoke. And this is a group that received intensive counseling, like more hours of counseling or discussion, and also medication. So if you give your patient the proper time and the proper attention to discuss their health behaviors or their health related behaviors and try to modify it and make it more hygienic and more useful for their health, in this case you are significantly helping your patient to avoid some diseases. Okay, so this was primary prevention. Then we have secondary prevention, and secondary prevention is the third level of preventive medicine that we apply in order to find early cases. So secondary prevention aims to find the disease in the early stage, which is the asymptomatic stage. So during this stage, the people have the disease, but they don't have any clinical symptoms yet, and you want to find those people. So you will screen, let's say, 10,000 women who are at some risk of cervical cancer, and out of these 10,000, you found out that 100 of them have risk factors for cervical cancer. So based on this information and After finding these 100 cases, you can order further screening tests or further diagnostic tests in order to confirm a diagnosis to see if they really suffer from this disease or not. So this is simply the first step of secondary prevention. The other step of secondary prevention, after you establish the diagnosis and you make sure that this disease is present, is to give the treatment. So secondary prevention is simply a two-step process that involves screening test and follow-up diagnosis. This is the first step, and the second step is early treatment for those with the condition of interest. Okay, then you have to think of the examples of screening tests that we use. It starts with history taking. So when you sit with your patient and ask them questions about their history, about their family history, about their previous behaviors and other like items of the anamnesis, you are doing a screening or already diagnosis. Then physical examination. This can include blood pressure measurement, laboratory tests like checking for proteinuria in a diabetic patient, other procedure like bone mineral density examination, like in this device that you see here in the end of the slide. It's DEXA, and it's just an example of radiographic examinations. Okay, so all these types of exams that you see also in the pictures are examples for the methods we use to diagnose for diseases or screen for diseases. And very soon you will learn the difference between screening and diagnosis. Okay, but before we learn this difference between screening and diagnosis, let's see the principles that were proposed by Wilson and Youngner in order to decide whether screening is useful or not. I mean, if you will design a screening program for, let's say, breast cancer or cervical cancer or lung cancer or whatever other kind of cancer in your population, you need to ask yourself some questions. The first question is about the condition itself or the disease itself. Is the disease really important health problem or not? Okay, this can be measured by the causes that are associated with its treatment or the consequences that this disease lead to have for the patients, like can the people die from this disease or not? So these are all questions about the condition. Then you should think about the treatment. Is there any accepted treatment for the patients with this disease or not? Like, yes, we can find that this disease is present in 1% of the population, but after we know this information, is there any effective and accepted treatment for these people or not? If the question is no, then we probably waste our money and our time in making this early screening, because regardless of the time when the disease will be diagnosed, we have no accepted treatment yet. Then you need to think about the facilities for the diagnosis and treatment. Do we really have them, or can we afford them from our, like, let's say, yearly budget or annual budget for the city or from the place where we work? Think about the early stage or the early symptomatic stage of the disease. Is there a stage like this or not? Because if the disease does not have this early symptomatic stage, then there is no point of finding it early. For example, we have diseases like common cold and others, and these diseases have very short early symptomatic stage. So if you find the disease early, you will probably make no benefit for your patient. That's why if you do screening program for common cold, then you definitely wasting your money and your time. Think about the test or the method of the examination that you're gonna use. Is it really suitable? Is it really easy for the doctors and probably nurses to use or not? Think about the population itself as themselves as well. Will they accept this method of examination or not? Is it like culturally and psychologically acceptable? Think about the disease again, and whether this disease have like enough time for being diagnosed early until it's like normally diagnosed, and whether this period of time enough for making effective treatments or effective early treatments specifically. Think about the policies that you should modify or you should have in place in order to apply this screening program. Think about the cost of case finding, whether it's justified or not. And finally, you have to think about case finding or screening programs as a continuous effort, because it can't be done as once and all for all project, because you need to keep monitor the people, because the people may not be sick today, but maybe in like few years you will start to be sick, and you need to continuously do efforts in order to find the cases as early as possible. Okay, you need to also think about the causes, as I said, associated with this regular screening. Okay, so these are the 10 questions or the 10 principles that were laid by Wilson and Youngner in order to justify screening programs. Okay, in this table you can see the questions reorganized according to the three domains of the screening process: the disease, the screening test, the diagnosis and treatment. So the first question about disease: is a disease important health problem? Yes or no? Is the natural history of disease well understood? Like, do we really know the stages of this disease and how long it stays usually or approximately in each of these stages? Is there a long time between the presence of risk factors until the overt disease? I mean, is there like a long time for subclinical stage, basically? Does the early intervention improve the clinical outcome? Because if early intervention is not really different from late intervention or late treatment, then the whole point of making early screening is not justifiable. So also the early treatment should be effective compared to late treatment or average or normal treatment. Okay, so this is the questions about the disease. Then related to screening test, is the test valid? I mean, in terms of accuracy, like sensitivity and specificity, and within the classroom we will learn more about these concepts. Is the test simple, reliable, and affordable? Is the test acceptable to patient and staff, medical staff? Yes or no? If the questions for these is yes, then we have a strong probability or likelihood to accept this screening program or apply it. Then questions about diagnosis and treatment, like is access to diagnostic facilities available and rapid? Like, can the patient find the diagnostic center or screening center easily? Can they access it? Is it far from their location of residency or not? Is treatment effective and accessible? Is it cost effective? Is it suitable? And does benefit outweigh the harm? Because we know that for some screening methods, there could be some associated risk related to the invasiveness level of this method. Like, for example, when you expose the people to radiographic examination, you also expose them to radiation. And we know that certain amounts or certain levels of radiation can be harmful and may cause some diseases, like even cancers, to bone and bone mineral. So we need to be careful and not expose the patients to unnecessary amounts of radiation. So all these questions need to be put into consideration when we decide about the screening programs that we would like to apply. Okay, so in this slide you will see an interesting phenomena about regular screening. So when you apply regular screening, for example, for a population like this one, and in the first year you started the screening in 2000. Okay, so the first screen round that started in 2000 included all the previous active cases, and as you can see, this is probably 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. These are probably 10 cases that were previously existing, and when we did the screening program in 2000, we found all these previously existing cases. Okay, then as we say, this activity or this screening program will be conducted every 5 years or on regular basis. That's why in the second round, which was the round of the year 2005, we have seen the cases that emerged only between the year 2000 to 2005, and this is only small fraction. As you can see here, it's only 4 cases. Okay, and we consider these cases to be the incidence cases, and that's why this second screen phase is called the incidence screen. Okay, then the third and the fourth screen rounds are not different from the second one, which is a 2005, because each of them included only few number of cases compared to the first one. So the first screen round usually includes the largest number of cases, because it includes all previously existing cases, and that's why we call this first round of screen as the prevalence screen. But starting from the second round and all subsequent rounds or all the later rounds, we see only the new emerging cases, and these are considered to be incidence screen rounds, and that's why all the second, like all the rounds starting from the second round and the later ones are considered to be incidence screens. Okay, so this is the difference between prevalence screen, the first one of 2000, and these incidence screens that are 2005, 2010, and 2015. Okay. So this is the difference between prevalence screen and incidence screen. Now we will see these three main sources of bias for screening activities. So screening is, as we said, important intervention that we can do in order to find early cases and try to help them and to prevent aggressive disease that can happen during the clinical stage. But we need to be careful because screening as a process is not perfect. It has a lot of sources of bias that can make it less accurate or less effective. One of them is lead time bias. So what is the lead time? Okay, I will explain now in this graph the lead time concept, and then I'll explain the bias that is associated with lead time. Okay, so imagine a human that started to have lung cancer at the age of 50. Okay, and this human didn't know about this disease or about his illness until he became in the age of 60. So the disease started to take place at the age of 50 as a subclinical disease. The patient was not aware about his illness for 10 years until he accidentally discovered it by diagnosis, or he had some symptoms, let's say, that required medical attention, and then when he did the examination he found out that he has this disease, and so the diagnosis was established in the age of 60, and he started to have treatment, yes, but unfortunately he died after 5 years in the age of 65. So technically, when you look at this case, we can say that this human who was unscreened, he didn't receive any early screening, he knew about his illness, as I said, randomly or accidentally when he had some clinical symptoms at the age of 60. So this unscreened case have 5 years of survival because the period between the age of 60 when he started to know about the disease or the clinical diagnosis was established until the day of mortality was 5 years. Okay, so this is the unscreened case. Imagine if this human was screened. So again, we assume that he started to have the disease as the stage of at the age of 50, but now the situation will be slightly different because he will learn about his illness at the age of 55, and so he will live until the age of 65 with this disease, which means that he will live for 10 years with the disease. So if you look at these two examples, you will see two humans. Both of them have started to have the disease from the age of 50, and both of them died at the age of 65. One of them was unscreened, and the second one was screened. So what we can look at here is the period of time that they were aware about their illness, and this period of time was longer for the screened person, even though the early screening didn't do any difference for their survival. They both died at the same age, but what we can see as different here is these additional 5 years that happened because of early screening or early finding. And these additional 5 years that we see from screening is what we call the lead time. So the lead time is the period of time between early detection through screening and normal diagnosis through clinical diagnosis. So normal diagnosis or clinical diagnosis is usually late because it happens after the clinical disease start to take place, and so the period of time that is between early screening and normal or average diagnosis time is what we call the lead time. And be careful because the lead time here increased the time of survival, which is 10 years, but it didn't give any benefit for the patient. So when you look at these two cases, you may think that screening helped, but in fact it didn't really help because both patients died at the same age. But imagine if the patient who got screened got also a successful treatment or a treatment which was more effective, and in this case he will learn about the disease also at the age of 55, but he will die at the age of 75. So in this case the survival will be 20 years, and in this case also we can say that the additional 10 years that were gained in this human is improved survival, and this improved survival happened because the screening program was associated with effective treatment. And in real life, it's very hard to differentiate between these two screened individuals, like the second and the third one, whether the treatment was effective or not, because we cannot see these graphs in real life or in real data. Okay, that's why lead time bias is always there. It increases artificially the time when the humans are aware about their illness, and so they can like affect or make us overestimate the effectiveness of screening programs. Okay, some diseases have short lead time and some other diseases have long lead time. For example, lung cancer have very short lead time. That's why we don't do like regular screening programs for lung cancer, because there is no point of doing it. And on the other hand, we have diseases with long lead time like cervical cancer. That's why screening for cervical cancer is still recommended in some places or in some countries. Okay, all right, so this is the lead time, and this is how it can affect our measurement for the effectiveness of screening programs. Then we have another problem which is called length time. And please be careful, because length time is not the same like lead time. If you look at this graph, you can see different tumors. So each line that you see here in this graph are certain cancer. And what you need to know before we start with this example is that not all cancers are the same. So cancers are not behaving in the same way. Some of them grow very rapidly and others grow very slowly. So if you look at these blue cancers, you can see that they grow very slowly with the time compared to their size or their stage of development. However, the green ones are probably moderately growing. They are not slow, they are not fast, they are like in between. And these purple cancers are very rapid or very fast, because they grow in size and their stage very in very short period of time. Okay, so as you can see, cancers are not behaving similarly, and that's why we need to be careful. Why? Because these rapid cancers are not equal to these slow cancers. The rapid cancers will usually be found through clinical diagnosis, because the cases will manifest themselves in very short period of time and they will require medical attention or medical care. That's why the patient will come to the hospital and they will be found like in very short period of time. Okay, so this is the cases that were diagnosed, and this is the stage or this is the size of the cancers that can be found by clinical diagnosis. Okay, and so the rapid cancers will be found before anyone else or before any other cancer. And on the other hand, there is a lower or a smaller side of the cancer that can be found by screening. So the cancer does not need to be very large until this point in order to be found by screening. It can be still in early stage or small size in order to be found by screening. But we need to apply this screening for the cases also in like regular times. So imagine if we did the screening in this year. I mean, this is the time when we did the screening. Okay, let's say this is the year 2000. And so the cases that are in green color are the only ones that can be caught by this screening. Why? Because the purple ones are too fast. That's why they didn't even wait for the screening to take place in the year 2000. So they were found by regular diagnosis or by normal diagnosis in hospitals. And so the green ones were slower. That's why they waited for the screening that took place in the year 2000. But look also at the blue ones. The blue ones are very slow and they probably benign as well. That's why they don't have bad prognosis. I mean, they cannot lead to mortality, for example, and that's why they didn't even get the chance to reach the size that is detectable by screening. That's why they missed the screening this time. Maybe in the next round of screening, these slow cancers will be found. If we have another screening round after 2 or 3 years, then these like blue ones may have the chance to be found, but probably not all of them, because the slowly growing cancers are usually more benign or less aggressive. That's why they have lower risk of mortality. Okay, so what we can learn from this case or this example is that screening usually capture the less aggressive cancers, because the more aggressive cancers are usually found by normal diagnosis or active diagnosis. That's why the green ones, which are the screened tumors, have better prognosis because they are slower than the worse one, which is called the interval cancers or the interval tumors. So interval tumors are the tumors that are found by clinical diagnosis, not by screening, because they are aggressive and they are fast or they are rapid. That's why they do not wait for screening to take place in order to be captured by screening. However, the screened tumors are usually the less aggressive tumors. That's why they are not very dangerous, and usually their outcomes are better than the more rapid one or the purple ones. Okay, what we can think about here regarding the effectiveness of screening programs is that we usually in screening programs see the better tumors or the screened tumors which have usually better prognosis. Okay, which means that sometimes we overestimate the effectiveness of screening programs, not because screening programs are not effective, they are definitely effective, but because the type of cancers that we are technically able to capture in screening programs are the less aggressive cancers. Okay, not the most aggressive ones. The most aggressive ones are excluded because they are usually found by diagnosis, as we call them, interval tumors. Okay, then we have the third type of bias, which is compliance bias. And this is very interesting because compliant patients who regularly go for screening are those who have better outcomes. We don't know for sure why they have better outcomes compared to those who are unscreened. But for example, you can think about their education level because those who have better education usually take more care or give more attention to their health. That's why they are more motivated to take screening services, and that's why they could have better compliance toward the treatments, and that's why they could have better outcomes compared to those who have lower education level, and that's why they are more resistant to get screened, and that's why they don't want to be screened. And definitely their outcomes could be like less uh, uh, yeah, less effective or less better, yeah, no, so worse worse than those who have compliance. Okay, so these are the three types of bias. You can read them later from the textbook, and the mechanisms or the techniques that we apply in order to control them. For example, in lead time we measure the mortality rates, not the survival rates. For length time we do controlled trials to compare between unscreened and screened groups. The same also for compliance bias, we compare between screened and unscreened individuals. Okay, so now we will go to the part which is I promised at the beginning to look at, which is the difference between a screening test and diagnostic test. Screening is the process of finding cases among the population. However, diagnosis is the process of establishing the diagnosis, or like making sure that the individual or the individual patient have this particular disease. Okay, so the purpose of screening is to detect potential disease indicators among a community or among a group of people. However, the diagnostic test aims to establish the presence or absence of a disease. So you diagnose a single suspected human to say if this human has this disease or not. Okay, this is the purpose. For the target population of screening, we look at a large number of asymptomatic people who are at risk of the disease. For example, women who have no breast cancer or cervical cancer, but they have family history of this disease. So we screen them in larger groups because we know that some of them could unfortunately have this disease already started. On the other hand, if we say that let's say 5% of those screened women have the disease or potentially have the disease, then we will diagnose them. So we will move them to the second stage, which is the diagnosis, and we will make sure that they have this disease or not. And that's why screening test is usually simple, acceptable for the patients. However, the diagnostic test is more invasive because it's applicable only for fewer portion or smaller portion of the suspected cases. The positive results threshold is generally chosen towards high sensitivity, not to miss potential disease. So in screening test, we try not to miss anyone. We try to include all potentially suspected cases, because we know that this is just an initial stage of making a decision, and then those suspected cases will go for more invasive test, which is a diagnostic test that is supposed to be more accurate or more specific. That's why we need to exclude the cases that does not have the disease. Okay, and you can continue reading in order to understand the positive result and the costs that are associated with both screening tests, because screening tests, for example, are usually cheaper, and they're supposed to be cheaper because they target a larger group of people. However, diagnostic tests are more expensive because they are associated with smaller number of patients. The positive result is important because in screening tests they indicate the disease presence, they don't confirm it, but for diagnostics test we need to give definite diagnosis or confirmed answer. Okay, so please reread this table on your own and revise it very well for your exam and your robot. Then we have quick like conclusions from this table. Uh, for example, screening tests are usually developed as diagnostic tests at the beginning. So all these screening methods that we use in screening programs have been primarily developed as diagnostic tests, and then after some time we decide that we can use them for larger number of patients in order to screen them. Okay, then the diagnosis as a process in general is not perfect, and within the classroom of this seminar you will learn how this is the case, because yes, you make a decision that this patient could have cancer, but you cannot be 100% sure. You, like in the good cases, is sure by you are sure by 95% or 90%, but you cannot reach the 100% of certainty. It's technically impossible. And why it is impossible? Why it's impossible? Because the um, methods that we use for diagnosis or screening are not like valid independently. They are valid, or they are decided to be valid based on a comparison to previous tests. So we have reference tests or gold standard tests, as we call them, and we compare these new tests or these new methods in relation to these previous ones or these gold standard ones. And if they are very similar, then the accuracy of these new tests or these index tests will be high. If they are different, it means that they will be lower. Okay, in the classroom of this week, we will learn more about the metrics and specificity, sensitivity, true positive, true negative, false positive, false negative. All these terms that you hear now will be explained in detail in the classroom. Okay, finally, we have to look at the challenges of screening, and we have 4 challenges of screening programs, or 4, I would say, adverse outcomes of screening programs if they were not strategically planned. The first problem is called the risk of false positive result. So what does it mean, false positive? It means that you have a human that have been told that he has a disease or she has a disease. However, this human is healthy. So the result of this test was not accurate, it was not correct, because the human is healthy. However, he was told that he is not healthy. Imagine the consequences that this human will go through or will have, regardless of, or in addition to the psychological impact that we will talk about later. These human will undergo sometimes invasive diagnostic surgeries in order to see if they have this disease really or not. And these invasive surgeries could have adverse reactions or adverse outcomes that are supposedly not needed from the beginning, but unfortunately this patient had to undergo this unnecessary surgery because the test was not very accurate. Okay, so this is the first problem. The second problem is the risk of negative labeling effect. So imagine that you told someone that he is unhealthy, however he is healthy. So again, this human get wrong information about their health, and so they will be sometimes extremely worried about their health, and this worry or this anxiety that they will experience is usually or sometimes worse than the disease that you have told them about. So because they are definitely healthy and they don't have this disease. So this is one of the problems that we can get from screening activities or screening programs that use not very accurate methods or accurate tests. On the other hand, you can also tell someone that he is healthy, however he is not healthy, and in this case this is called positive labeling effect, and yeah, this can be not very bad, but it can also be dangerous if the disease is invasive, and then the patient will discover later on that he missed the opportunity to be early diagnosed and early treated. Okay, so this is the second problem. The third problem is called the risk of overdiagnosis or pseudo disease. What does it mean? It means that you have found a disease that is not really a disease. The good example for this is the prostate cancer. The prostate cancer is a disease that is usually commonly found among young males. So young men or young males can experience increased levels of PSA, which is prostate specific antigens, and these increased levels could indicate high risk of getting prostate cancer in the future. But the patients or those young men do not have the disease at their middle age. They usually have the disease at their 50s or their 60s. So it will come probably after 30 years from the time of the early diagnosis. So they will live for 30 years with anxiety and worry about their health. And the surprise here is that the vast majority of those males will not get prostate cancer at the end. That's why this is an example of lens time bias, which is the tumors that take years to be developed, and they will not cause any tumor or cause any cancer at the end. So don't worry, not all tumors that you will hear about or that you will learn about are cancers. Many of them, or actually the vast majority of them, will not lead to mortality or real death at the end, because they are more to be benign or more to be less aggressive. Okay, so finding out these diseases is in fact fake diagnosis or fake disease or pseudo disease, because this will not lead to actual disease at the end. That's why today we do not apply prostate cancer screening or recommend it, because as I said, it will lead to a lot of people suffering from anxiety about their future health, and at the end they will not have these diseases at all. Okay, incident trauma, or the fourth problem of screening, is also an interesting phenomenon, because with the development of radiographic examination methods like CT or computed tomography, we can visualize larger areas of the human body, and these larger areas of the human body that are not really needed to be seen can indicate some diseases that are not interesting and interesting for the original purpose of the screen. And so we can find diseases that, as I said, are not interesting for us to be found, and so we will spend a lot of money to treat them, and interestingly enough, these diseases will not lead to mortality as well. Okay, so this happened with the CT of colonography or the colon. So the patients who do CT or undertake CT for their colon to see some problems in their colon, sometimes the doctor or the physician can see problems in the abdomen and the lower thorax, and that's why they can refer the patient to other colleagues to deal with these problems. But interestingly enough, these problems could be trivial and they could not lead to mortality at the end. But yet, this is again an example of waste of time and money of the patient and health system. Okay, so these were the main problems of screening, and now we will move to the last part of this pre-record, and it's pre-seminar record, and it's tertiary prevention. So tertiary prevention is the fourth level of preventive medicine that is focused on people who have the disease. So imagine a human who have already a disease, and now we need to focus on the long-term consequences of the disease, because diseases do not cause only short-term outcomes, but also long-term outcomes and long-term problems. And that's why tertiary prevention is oriented to focus on the long-term outcomes. And the example that you can read here is about diabetic patients. So the good medical treatment for diabetes is not only to control the blood glucose. This is the clinical treatment, basically. So if you have diabetic patient as a clinical treatment or as a short-term outcome treatment, you can control the blood glucose through metformin or insulin or whatever other medication. But it is also important to look at the long-term consequences or the outcomes of this disease and how we can control them. Because we know that diabetic patients are among the high-risk groups for cardiovascular disease like hypertension, hypercholesterolemia, obesity, and smoking, which are the risk factors for cardiovascular disease. So we need to make sure that diabetic patients do not have these diseases, do not have these risk factors, because if they are engaged with these risk factors, it means that they will have, I would say, certain risk of cardiovascular disease. The same also for diabetic retinopathy, and so we need to regularly check the ophthalmic functions of the diabetic patients. We need to make routine care for their feet as well, because this can lead to neuropathy. I mean, the diabetes can lead to neuropathy. The same also for urinary proteins and other risk factors that can be indicating problems that are associated with diabetes mellitus. So looking at all these other diseases that could be associated with diabetes and the risk factors that can lead to these diseases and control them is the example of tertiary prevention. So tertiary prevention is oriented to long-term outcomes and chronic phases of illnesses. Okay, these were probably everything that you should learn before coming to the classroom this week or this seminar, and I hope that you understood it clearly from this presentation. If you have any questions, I will be happy to answer these questions in the classroom, and please also watch the other videos that I will post in the information system that you have to watch before you come, because they will probably explain the types of lens time, lead time bias, and other biases of screening and other topics, maybe in a different way than what I already used here. That may help you to understand it better or in a more comprehensive way. Thank you for your time and see you in the classroom this week. Goodbye.